Good morning. My name is Dr. Chalam, and I am joined here with my esteemed colleague, Dr. Nagpal from India. I am from United States. Today, we'll be covering the advances in viewing systems and implementation of them during vitreoretinal surgery. So I'm going to start the lecture, the viewing systems for vitreoretinal surgery. That is the topic today. And I'm going to give, as I said already, my name is Dr. Chalam. I am a professor and chair at Loma Medical School in Los Angeles, California. And it is a two-part presentation, and I'm going to go over the basic optical principles and how the systems develop over a 30 to 40 year period. And then Dr. Nagpal will show you the examples utilizing this technology and give you some tidbits of how to improve the visualization. At the end, I think we'll have 20 minutes of questions and answer session. And we welcome the audience to not only participate, but please send us anything that you think of use to the common audience. So I'm going to divide this 20-minute presentation into multiple segments. Number one, how much retina is there for us to visualize? Number two, how do we measure what we are actually seeing? And what are the factors that influence both biological and optical in visualizing them? Imagine like a wallpaper on a wall, which is very, very easy to see if it is a rectangle and plane. Unfortunately, we have a cornea, which is spherical in the way, limited by an entry of the image, both input and outputs through the size of the pupil. And of course, the spherical shape of retina makes it difficult to see the area that is anterior to the equator, for a variety of reasons that I would go over. So let us start how much retina is there in actually human eye. Using the geometric models, a 24 millimeter normal average human eye has between 11.5 to 12.5 square centimeters of retina wrapped starting from the disc and ending at the ora serrata. It is round in shape. It is more in size in temporal than nasal. And obviously it is much larger in size, the surface area in myopes than hyperops. So this is a picture that is taken with an Optos wide angle system. As you can see in the clinic, in the center, you have the temporal retina, nasal retina, inferior retina, and superior retina. This you want to visualize during surgery, just not only be able to see. So the geometric dimensions, depth of focus, all of them are important factors, and they tend to get into more importance in the periphery because you don't want to damage anything and don't do anything that you can't see during surgery, which is a very important point. So the confusion between the visual angle and eye angle, I want to clarify. In this presentation, the degrees of measurements, we are going to use the visual angle, which is the area that is point that is measured, that is located in the posterior capsule area of a human eye. And what is the importance of it? Any rays that goes in and out are not deviated if they go through the nodal point. That's why we want to take that as a point. In the second picture, you have the eye angle, which is measured from the central point of the eye. And this is used in describing the camera systems, and that's how this develops. So how much retina is actually there in terms of degrees? Now that I have told you the surface area, the second part is, it is 170 degrees. In other words, if you draw a line from the posterior surface of the line, say, straight line, so you normally hit a little bit of the pars plana, posterior pars plana, and just a millimeter behind is the ora serrata. So you roughly have 170 degrees. That's the maximum that you can have. And the eye angle, on the other hand, if you measure from the center of the eye, then you have 240 degrees of retina that is there. So when we started the vitrectomy in the early 80s, we just had a simple plano-concave lens. In the beginning, we used to put a viscoelastic and in areas where we don't have access, just a slip lens, cover slip that we use in microscopes on the top of the jelly to get the visualization. However, the lenses were made, as you can see here on the right-hand cartoon, the lens that is placed with a small viscoelastic on the eye. So while the good thing is that you get a direct image of the retina, the amount of area you see is extremely limited, especially by the size of the pupil. And even if the pupil is dilated to 9 millimeters, you can only see 30 degrees. And the other thing was we have to have something to hold it. So we used to have a ring that is sutured. which takes time, bleeding, to neutralize the corneal spherical surface to get the view of the retina. So you could only see 20 to 30 degrees, and at the most, it was only 4 square centimeters of retina. Unfortunately, most of the pathology we address during surgery is located either in the equator or anterior to the equator. So that made life very difficult. So we used to use scleral buckling a lot more because of that. So here is a cartoon, and the next development was to develop the some foot plate, so that way, we don't have to switch to the ring. And this was in the early 2000. The Voc Optical came out with this lens. They have two sizes, one for the children on the right-hand side and the adults on the left-hand side. This improved the visualization, reduced the operating time. Then the next order of business was, can we add a prism on one of the sides to improve the view? We could do that. The problem, of course, was your stereo perception suffers when you use a prism. But that was what we had, and that was we had to contend with. So we went to extreme degrees in those days, put a light on the lens with a scleral depression in here. You're seeing an autocerata with a direct system, and how difficult it is to do any manipulation in that area, especially in cases like anterior PVR. So naturally, logically, we turned to the indirect ophthalmoscopy systems, which we are using in the clinic, where we can actually see the periphery using indirect ophthalmoscope. And here it is a cartoon showing you the direct system, and you can see the amount of retina that's not actually seen. Obviously, our goal was to see that area. And so indirect ophthalmoscopy system, can we use it? So one of the advantages is if you use a 28 or a 30 diopter lens, instead of 20 degrees, you get to 60 degrees at one site. So that was great. So can we do that? But obviously, the lens was so big, we can't use it in the operating room. So we had to miniaturize it. And then if you miniaturize, obviously, you can get a large area of retina that can be seen. So the calculation was optically, how much lens can you manufacture comfortably without distorting because the weight of the lens can cause problems for the geometry of the eye. So the limitation was 150 diopter lens can be made. That's what Voc Optical told us. So we said, well, let's go for it. So the view obviously improves a lot, but you get a minified image. So how do you deal with that? So then we have to use the microscope. So for example, here is a 150 diopter lens, giving around 110 degrees of retina, which is roughly around 10 centimeters of the retina on the surface area you could comfortably see with a dilated pupil. So the amount area that you see is limited either by or increased or decreased by the diameter of the lens and the dioptric power of the lens. So the limitation was 150 diopter lens, but the diameter of the lens was limited because in vitrectomies, you have to have the ports entry, and that cannot obviously impede on our ability to go in and out of the eye. So that limited the diameter of the lens. So one other problem that came with us was basically, unlike the direct system, you have a plano concave lens, an indirect system produces an inverted image, which causes also a problem in surgery. So we had to do inverted prism in the microscope in order to get around it so that you can get as you can see here, we have to, inverted image has to now operate in left corner, and you have to correct orientation has to be maintained, and also preserve the level of illumination, because this prism cannot also impede the amount of light coming to you. So that is also important for us to keep in mind. So we used a prism. So this is an attachment in the beginning. It used to be made by various companies in various forms. Here is a Voc Optical inverter system. Then I will go over the other systems later in the talk. So with that, we got around one, the area now we can see. Number two, we can magnify using the microscope. Number three, we can correct orientation with the prism. So that's essentially any indirect ophthalmoscopy systems are comprised of optically. So here is a composite picture of it. As you can see, this is the eye. The lens is placed on it. The image is formed, between the lens and the microscope. And then by zooming the microscope, you can go to whatever level that you need appropriate. So this is a close-up view of it. And actually the image forms around 6 millimeters from the anti-surface of the lens. So this is a composite diagram of the eye, the lens placed on the patient. Then this is the objective lens of the microscope, and the surgeon is sitting on the right side in this cartoon. And this is in the contact systems, you have a plano concave lens that has no power, just neutralizes the corneal surface. And the closer the lens to the nodal point of the eye is, the wider the view that you actually get. So that's very important to keep in mind. That's why even in non-contact systems, the closer you are to the eye, the wider the view you actually get. So now that I have covered the basics, let's go into various systems that are available on the market, the advantages and disadvantages of each systems. So broadly, you can divide them into contact systems and non-contact systems. So the contact systems, you have basically Voke Optical makes the contact system and AVI makes the contact system. The commonality, however, is the lenses are made by the Voke Optical for both systems. The non-contact systems, there are multiple systems all over the world, but at least in the United States, the Resight made by Zeiss, Merlin made by Oak, Biome made by Oculus, and IBOS are the common one that are used. And I'm sure there are other modifications in various parts of the world. Here is the contact system, RV system, where you have an inverter, and it is not actually need anymore because most microscopes, both Leica and Zeiss, comes with a automated inverter inbuilt in them with the advanced models. And on the right-hand side, you have two lenses, one that covers around 70 degrees, and the other one basically does around 160 degrees. So this is a Voke optical inverter. As far as the non-contact systems are concerned, there are four systems I'm going to go over quickly. This is the composite diagram of no matter what non-contact system you're using. The difference is here, you're not touching the eye, and you're roughly, depending on the lens you're using, roughly a centimeter from the corneal surface, and the rest of the other parts of the system is exactly the same. So this is a Merlin system of the Voke. Then you have three lenses they supply, one for the wide angle. Then there was one for small diameter in the midfield, which you can change depending on the needs during your surgery. And this is a Resight system that has two lenses. The green one is 60 diopters and the yellow one is 128 diopters. This has become quite popular because the Zeiss has microscopes are commonly used, and this system comes with them. So this has gained market share more recently. So this is a Biome system, which has been used since 1987, one of the oldest systems, and is also used in most parts of the world. However, the optical principles are the same. So this is the more advanced, more recent Biome system that gives 130 degrees field of view. So one thing you have to remember is no matter in non-contact systems, the lenses that are used is 128, 130, or 120. So as I told earlier, the limitations are the 150 degree diopters is really the one that comes with the contact system, gives you roughly around 20 degrees more field. Added to that, around 5-6 years ago, I made some more modification. Now we can use a high refractive index. So we can go from 154 degrees to 212 diopters of the lens. That is the HRX lens that is made by the Voke is actually covers up to pars plana without any depression, even in small pupils. That's what we call it an XL, HRX XL. And we'll talk about it a little bit more later. So anyway, what are the advantages of the contact system? Each of them have advantages and disadvantages quickly. The contact system eliminates the corneal astigmatism. The true curvature of the image enhances stereopsis, especially in the periphery. This is really important. In difficult cases like anterior PVR or trauma, and this is really important. So the surgeon has the freedom without causing any iatrogenic breaks. The corneal drying is prevented by using a viscoelastic, whether it is Helon or any of the commonly available. And it in places where you don't have the assistant, this also fits into the vitrectomy ring when it is not self-stabilizing model. So the field is 170 degrees of field. Literally, you can see the entire retina in one view. It's close because it's the increased power of the lens makes it rays go through the nodal point very close from the parallel surface. The aspheric nature of the lens is very important because the chromatic and spherical aberrations that are inherent in a lens is basically eliminated using the aspheric technology. The curvature of the image is maintained, and that is an advantage because when you zoom on the microscope, you are looking at a true field, not a distorted field. Imagine like a car mirror. Car mirror produces a wider view, but is distorted in real space. Whereas in this particular contact lens, the advantage is it maintains the real space and stereopsis that is so vital to healing the membranes in the periphery. So the advantage of the non-contact system, on the other hand, is unencumbered eye. So nobody has to hold it. So that makes it easy when you're operating by yourself. And there are no pressure changes on the cornea because you're actually not touching the cornea. So that's the advantage. So what are the influences? That is fine. What are the biological factors that we need to be aware of? Obviously, the view is much wider in pseudophakic because you're taking the lens out. The posterior curvature of the human natural lens tend to cause distortions. So phakic versus pseudophakic. The second factor that is not usually taught, that is very important, is the depth of antechamber. The deeper the antechamber, the less view you get. And the reason is because the nodal point is going posterior. So sometimes in difficult cases, I even tap the antechamber in order to get the wider view temporarily. And so keep that in mind. And if you're having difficulty, especially in a 2 millimeter, 3 millimeter pupil, this is a good trick to use. The third part is obviously if you change to gas, because of the change in the refractive index from 1.3 to 1, your view of the field increases. So if you do after air fluid exchange, you may find that you see a lot more than you otherwise. The fourth one is the pupil size. That's really important, whether it's the pupil itself or whether it is the lenticular problems like a posterior capsular opacification after cataract surgery, or it is a capsular phimosis, which is usually a problem in some cases where the cataract surgeon has done and the anticapsule became like a pinhole. And the other problem is sometimes you have these days multifocal lenses, which can cause also aberrations in the periphery. So the corneal astigmatism, we already talked about it by using, if somebody has a keratoconus or scarring, contact system is much better because you're eliminating it. The lenticular astigmatism, Alport syndrome are things where you have the lenticular astigmatism is a problem. Contact systems are better, or a posterior polar cataract, or any of those kinds of things. The two aberrations in any system that you have to keep in mind is a spherical aberration. In other words, if the rays goes away from your central point of the lens, you tend to have a prismatic effect. And since this is a very high power lens, like 160 dioptric power, you need to be aware of that. The other part of it is the paraxiality. That basically means if it is perpendicular when you're viewing, you don't have a problem. But if you rotate the eye instead of viewing paraxially, that can cause distortion. And you need to be aware of that during surgery. So the effect of the pupil here, as you can see, the smaller the pupil, the less the view. The minimum pupil size that's required is you at least need a 3 millimeter pupil dilation for a non-contact 90 diopter lens. And you can get around it even up to 2 millimeters pupil with a 150 diopter lens. Of course, one has to hold it perpendicular to that area to get. So this is the optics of the air when you do after air fluid exchange. As you can see here, your view extends much bigger to 130 degrees to 170 if you can do what we call as dynamic viewing by moving the lens on either side of the nasal or temporal. So in summary, what are the tips and tricks? Then the lenses, whether it's direct or contact or non-contact, it has to be perpendicular to the eye. The obtained image, when you look through the microscope, should be round. If it is distorted in one or the other, that means you're not paraxial. The IOP should be as physiological as possible, because if you have hypotony, you'll have a problem. And in the same way, if you have increased intraocular pressure, your cornea gets edematous, and then that can cause trouble. Corneal anti-surface is where all the action is, so it should always be wet, whether with these methyl cellulose in non-contact systems or viscoelastic in the contact system. And when you're doing surgery, be careful of differential pressure on sclerotomy sites. If you exert pressure on one versus the other, especially for learners, this can cause oblique astigmatism, and that is important because it can interfere with stereopsis, especially if you're doing complicated diabetic surgery or complicated PVRs, that you want to have that stereopsis. That is important. Well, I think I came to the end of my talk. And now I introduce and welcome Dr. Nagpal, who is going to show you multiple examples illustrating the various points I alluded to. And look forward to your questions soon. Dr. Nagpal.
Thank you so much, Dr. Chalam. This is by far one of the best talks that I've heard related to the optics and about the whole concept of contact, non-contact, and the differences that allow us to do surgery in the best possible way. For me, the concept is when they say vitrectomy, I say it's all about the view, because no matter what technology that you would use in terms of cutters, viewing machines, unless you see the whole field of view or the area of interest very well, I don't think you can perform using that technology. So it's all about the view. So let's get on the bandwagon and get on the flight, tighten our seatbelts, and look at to the view. So what I use typically is the contact-based systems. You've already heard about the differences between non-contact, contact, and my go-to lenses are these two primarily. For wide field viewing, it's the Vogue HRX or the Mini Quad XL, and for macular, I use the flat lens, which is what allow me to see the best possible views on these. And this is, as you can see, that the contact-based systems are put after some viscoelastic is put on the cornea, and after that, you can put it on the corneal surface, which would allow, and I prefer the ones with the flanges because they help you stabilize the lens much better. Here you see that this is a typical field that of my surgical field, where I put the lens and I sometimes use my index finger to stabilize it. With the flanges, keep it stabilized, but as you move the instruments, at times it gets tilted. So the index finger with which I hold my fiber optic, I also use it to stabilize it and get independence. One can also use handles held by assistants to achieve the same as well. So this is typically how I would begin a surgery. Put in the lens and then start getting the field of view. And as Dr. Chalam said, that these wide field viewing lenses, you can go into an area of interest by zooming in, or wherever you require more field, you use that aspect of it, and where you need to zoom into an area of interest, you use your microscope to zoom in, and it allows you the flexibility to do both the things all together. So this is a case which had some peripheral tears as well as a macular hole. So as now that I've done the peripheral bit, I want to go to the macular area, I put the flat lens and then go in and see a much better magnified view of the area of interest that I have in this particular surgery. So this is grossly how I use the two different lenses in most of my surgeries. But every surgery requires the wide field view. The macular lens comes in when you have to peel a membrane or an ILM or do some fine work on the macula. But for almost all other cases or all other aspects is the wide field view. So this is a typical view. As you can see that I'm showing a PVD induction being done after triamcinolone staining in a detached retina. Now in a detached retina, the retina is mobile and does not behave the same as a macular hole PVD, where you can go in and effortlessly pull it. Here, the retina also moves and you're always worried about causing iatrogenic breaks. And so a well-stained vitreous with a good view all around allows you to see the whole field in toto as to how the vitreous is moving in relation to your cutter. This is a classic view of detachment with horseshoe tears. You can see that I've zoomed in. I usually prefer zoomed in views apart from using the field wherever required, but my area of interest always is based on the zoom. So I always like to zoom into different aspects using the maximum field, but go into areas like, so these are peripheral tears, but when you zoom in, you can go in close, you can see the actual vitreous adhesions which are there on the edges of these tears and the breaks, and you can remove almost every aspect of it. So this is a typical case of a detachment. I've removed the vitreous. I'm putting in some perfluorocarbons to flatten the posterior pole. And after that, once that's flattened, I aspirate it and flatten with the endo drainage, flatten it, and then do an endo laser to the tear and all the other tears as well. So you can see that all this time, I can keep a zoomed view of the area of interest that I want. It's also great from teaching perspective, because you might be showing something specific in terms of what you're doing in that particular surgery, and you could go in. And then when you need a full field, this is after an air-filled eye, and you can get a full view of the whole retina at the end of surgery. Now, this is a case where, again, there's a detachment with large tears. and it's a phakic eye with clear lens, and sometimes here to clear the periphery is difficult because you might go and indent or touch the posterior aspect of the phakic clear lens. So here at times what I do is use chandelier and indent from outside to bring the periphery closer. So, so cases where you have clear lenses and you are worried about clearing the peripheral vitreous, it's best to lower the IOP a little bit so that you can indent it with your other hand, or you could have an assistant indent it based on what you prefer. And I prefer to do it myself, so I put a chandelier and then indent it from outside if required. So this is something that you can use to bring in the periphery closer to you without damaging a clear lens, which otherwise is not a problem in pseudophakics or phakics, where you don't need to worry about that. Now, for some of these cases have breaks which get camouflaged, especially in very high myopics. And here you can see that the view you get is amazing. I use a cryoprobe to indent the periphery, and I am unable to see the break, and I sometimes do cryo search on them to make sure. And then I zoom into the area of interest to see that what that particular area, and you can see that when I use the cryo, the break will get, the horseshoe tear is seen quite well in the extreme periphery. So every area of interest can be specifically looked into using these. And like Dr. Chalam said, that the medias make minor differences once you are using these wide field lenses, unlike the irrigating lenses that we used to use in the past, where an air-filled eye or a saline-filled eye would be totally different. Here, air fluid, partial air fluid, PFCL, oil, whatever you put, all you have to do is slightly focus the microscope to get that absolute clarity, but otherwise you can see through everything. So now this is here I'm switching to air, and you can see that the whole air is filling the cavity, and you can see the whole fundus quite well. And this is a case of a silicone oil filled eye in which there is also sub-silicon oil which has gone in. So you can imagine these are I'm putting in saline infusion and removing the oil in the vitreous and put in perfluorocarbon in the posterior pole to push the subretinal oil. So many interfaces sometimes I work with. There would be saline, there would be PFCL, there would be oil, and these wide angle lenses are just magical. All you have to do is just defocus or focus and with your foot switch, and you can see through almost every interface as clearly as you can do with saline itself, which otherwise was not possible with the previous generation of lenses. Here you can see that I'm injecting some perfluorocarbon now after having removed the oil in the vitreous to push that subretinal globule of oil out, and I zoom into that area of interest to see that particular aspect. This is an oil-filled eye where there is a sub-silicone oil pucker which has formed. So here what I do is that I don't want to remove the oil. I've kept the infusion on air, and I've put in some perfluorocarbon under the oil. So this is an oil-filled eye with perfluorocarbon under it to give me a better kind of a hold, like a third hand, while I'll peel the membrane under the oil and under the PFCL. And the view is fairly good given all these interfaces with these wide angle lenses that I use. Giant retinal tears again is all about getting the best possible view, because giant retinal tears extend into the peripheries. They also have their whole peripheral margins. They have vitreous adherent to the margins at times, and you can do justice to it well only if you are able to get a good view of which is extending to the whole field right up to the periphery. And you can see that with these wide field lenses, you can go in. And I prefer the contact ones because of the crispness of the view that you get without any distortion as you work through the periphery with these cases. This is a case of a pseudophakic eye with a giant retinal tear, which is everted itself. And you can see that whether you see the rim of the IOL here, but it doesn't really bother you. It's there because you can't do anything about it, but you can still see everything clearly. You also see the peripheral edge of the tear, which is there, which you can remove separately and remove all the vitreous before you go in and put in perfluorocarbon to open up the folded edges of the tear. And here you can see that I've zoomed in on the disc and the macula. I just want to see how the retina behaves as I'm pulling, and then get the field wider when I want to do the laser to the periphery. And I like to do a PFCL air exchange. And so I keep a watch on the whole periphery, drying the edges of all the sides of the tear so that there is no slippage. And this is an air-filled eye with PFCL inside. I'm clearing it slowly, and you can see the view you get is fantastic right up to the periphery. You can also top up your laser up with the air-filled eye wherever it's missing a 360-degree, and then you could choose your tamponade of oil, gas, whatever in the situation. So the view is kept intact through this. Cases of these large subretinal hemorrhages, other eye of a patient having disciform scars, I like to surgically go and remove these using a peripheral large retinectomy. So for these eyes, again, you need a wide field view, a full view of the fundus to do justice to seeing the retina being everted. So here you can see that I've first put triamcinolone to remove the vitreous, make sure that the vitreous is gone. I put in some perfluorocarbon to check if the hemorrhage shifts itself or not, but it doesn't. So I'm doing some diathermy to the periphery so that I can make a retinectomy in that region. After doing a diathermy, I'm making a giant tear using the cutter. And once I have that, I invert the whole flap using the forceps. At this stage, you could also use a chandelier. You could have bimanuality based on whatever you prefer. And once I have clear exposure of the hemorrhage under the retina, I can eat it up with the cutter. So all this is possible only if you have a view of that whole area in toto of the whole flap, the eversion, and you can do justice to it. Once the hemorrhage is gone, I treat it like a giant tear. I unfold it back with perfluorocarbon. You can see that the hemorrhage is totally gone now, which was taken up. All you see is a residual hue of the pigmentary changes which are there under the hemorrhage, and then treat it like a giant tear and put in the oil inside. This is the post-op view of the same. Now coming to macular surgeries. Again, here the whole aim is to look at the macular area in the highest magnified way, especially for procedures for ERM or macular holes, which is what we use it for. And here you can see that ILM peeling is one of the most common procedures today used by everyone. People do all kinds of things with the ILM, peel it, stuff it, invert it, so many different things that they do. But for all that, you need a great view, and that's achieved using a flat lens or a central lens of the Vogue. I sometimes, based on the area I need, I switch from one to the other. This is a massager that we've devised. Sometimes I use it for larger holes or redundant holes to loosen the elasticity by a gentle massage atraumatically. And all these things you can do only if you have a crisp stereoscopic view, so that you don't create any iatrogenic break. And now, after doing air fluid exchange, you can see how clearly I can see that the hole has closed on table. Under the air, the view is fantastic. But this, of course, I shift back to a wide field lens to do all exchanges. The only time I switch to a flat lens is when I'm doing the macular part of the procedure. Now here there's a detachment with a peripheral break as well as a macular hole. So I use a wide field to clear the vitreous and then remove the ILM and the perfluorocarbon, use the massager that I showed you for this. And once finished the macular, shift back to the wide field, do the classic retinal reattachment using endodrainage from the break, and then doing air fluid exchange fully, draining over the macular hole and flattening it and closing it. This is a procedure for epiretinal membrane peeling, and you can see the clarity that you get with the flat lens, that crispness and the stereoscopic depth perception, which is extremely essential so that you do not pinch deeper than you are required to, because if you pinch deeper, you're going to pinch the retinal tissue and cause damage to that. And all this is a foveal area, macular area, a very crucial area, and you want to be as atraumatic as possible. And And this is the view you can achieve with that. And so after removing the ERM, we look for the ILM, and you can see that some of the shreds of ILM sometimes are chipped off when you peel the ERM, but the stain of brilliant blue tells you exactly where the ILM is and where it is not there. And you can do justice to whatever you set out to do with the ILM in this case. This is another case where you see a small vascular attachment on the membrane, which oozes out as I peel. But the magnification helps you constantly assess the retina underlying. Now, this is a slightly neovascular component, and so this membrane has these adhesions which slightly bleed. But you can keep a watch. Your concern is that is the adhesion so strong that it may create a break or not? But no, I can keep a watch by zooming in exactly under the retina, under the membrane, and look at the retina throughout my peel so as not to cause any inadvertent break or pinch deeper than required in a certain case. You look at vitreomacular tractions, and you can see the it's very important here that we do not just pull off the PVD, because you may de-roof the macular into a macular hole here. So here what I do is, this is a stained hyaloid, and I want to see it very closely, so I put a flat lens and want to have a magnified view, and only after removing all the peripheral attachment of that hyaloid attachment, all that remains is a tip of the hyaloid which is touching the fovea, and this is best removed by just peeling off the ILM rather than trying to pull it off, and that's the safest way to do it. And you can do it safely only if you have good visibility, because if you do not have crisp visibility, this is the time where you can pinch deeper, or you could de-roof the macula. These are pathologic foveas, and you could de-roof them at any point of time. As you can see, there's a small ooze which has come up. In spite of having great magnification at times, a small bleed may occur. You raise the pressure, stop it exactly as soon as you see that happening, and then proceed with the rest of your surgery. This is a case of a dehemoglobinized sub-ILM blood that you can see, which was non-clearing over a month, and we decided to operate this. And you can see that the flatness of it, instead of a boat-shaped classic subhyaloid, this is a sub-ILM blood. So your first aim, of course, is to remove the hyaloid, which you can see that we have removed. Once the hyaloid is gone, then I put in the flat lens, and you can see the magnified view that you get. You stain the ILM, and you can see every granule on it, the parchment-like ILM which is stained, and the underlying crenated or dehemoglobinized blood granules which are attached to it. Every single thing you can see as it's being peeled, and you expose it. So now the blood is exposed. You can use your suction. I use the cutter suction to just aspirate that whole component of the blood, dehemoglobinized blood, to clear the fovea of that. And the view is excellent with the high magnification that you can achieve using the flat lens in this. And then, of course, you could go back to your wide field lens eventually. Now, there are situations where I use the central lens. Now, this is in between the two. There's a wide lens and there's a central lens. Central lens gives about 75 to 80 degrees view, and is excellent for diabetic dissections on the posterior pole. Now here, today, most of the diabetic proliferations we remove with cutters, sometimes with forceps, but hardly ever use scissors most of the times. And you can get fantastic views of the planes of these membranes in relation to the underlying retina using the central lens. Because here, if you use only the flat lens, your field of view is too less to look at the whole area of interest that you have. Well, if you use the central lens with about 80 degrees view, you get a fair view up to almost the equator, and you can keep on removing these proliferations, keeping the rest of the retina of area of interest in view, and it gives you excellent clarity as you do so. So here you can see again another example of diabetic dissection that you can do using the central lens. Or if you're peeling a subhyaloid hemorrhage and you want to see the plane of how the hyaloid moves, but you don't want a very magnified view of central lens, but you want to see the central retina as a whole, The central lens is fantastic with about an 80-degree view where you can see the way the whole hyaloid moves in this case. This is a case of a subretinal hemorrhage. Once again, in some of these thicker hemorrhages, I use surgical removal and I use a posterior retinotomy to remove them. And I reduce the cut rate to 100 cuts a minute to use it like a scissor. And it goes cut, 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 cut instead of the regular cutter. And then once you have an opening, I engage it with the cutter. So all this is done keeping the Vogue central lens, which allows me amazing view of the posterior pole as well as the area around it, and the whole complex is removed in toto with it at the end of surgery. Just a small clip on buckling surgery. I use the same Vogue lenses to do buckling surgery. The buckling surgery is done classically, but I use the Vogue lens under the microscope to do the buckle. This is great from teaching perspective, as well as it's good from a posture perspective for retinal surgeons in the long run. And you get views like this because the view is of a vitrectomy that we are used to for any vitrectomy surgery. All you do is put in a chandelier, a 25 gauge chandelier, and then you have a view of the retina. To show you one case where you see a detached retina in a myopic guy, and I'm indenting from the periphery. The view is from the Vogue wide field lens, and you can see the cryo being done on the break. After that, we localize it, do all the suturing under the microscope, localize it, putting the buckle, doing a drainage. Everything is done on the microscope, and whenever you want to look inside, and this is the buckle effect that is seen at this stage with the flat retina inside. So we typically now do most of our buckling surgery whenever we have to do, which is getting less and less, of course, but whenever we do a buckle, we use chandelier-based buckling using these Vogue contact lenses. So these are some of the examples of different situations where we use these contact-based systems to achieve wide field viewing, as well as a central magnified viewing, or a balance between the two. And you use the microscope to go in and zoom into areas of interest. Using all these things together, you can get a great view for all kinds of situations. A lot of videos of I post on the YouTube, and they can be on the channel as well as the cyber site on which we are right now using it as a platform to see a lot of these different videos which are there. So thank you very much for having me on this platform, and Dr. Chalam for creating this platform in terms of the whole concept of contact, non-contact viewing, and have really enjoyed sharing all these with you. And I'm stopping the share, and we are open to question and answers in the next 15-20 minutes. So I see a question. The first question is, which viewing system do you recommend for a new VR surgeon? Dr. Chalam, would you like to comment?
Well, it depends on what resources you actually have. All of them do a good job. But as Manish already alluded to, my preference is the wide angle system. It's kind of interesting. I don't know what Manish used, but those two are the one that was developed by me, and I'm glad to see that they're the one used. Plano lens, that's the most important thing for most of the posterior pole work, and wide angle system lens for all the things that I do. That's what I do normally. And also I've been doing buckling from using microscope since '95. So I never do with indirect ophthalmoscopy anyway. So I totally agree with what the practices you already mentioned. That's what our fellows do, and that's what we do. Speeds up the surgical process. Less time is good for biology, recovery, and all that kind of thing. I don't know where the anonymous attendee is located. If you have the resources, my recommendation would be, one of the advantages of the contact systems you have is they're very inexpensive compared to the non-contact system, as long as your microscope already has an inverter built into that. Then all you really need is get the lenses, and you can do everything that is done on what was shown. On the other hand, if you're talking about non-contact systems, they're all more or less same. The obviously Vogue systems has a little bit advantage of because of the lenses they supply, the glass lenses instead of acrylic. So the quality of the non-contact systems that, they're a little bit better. So in our own hospital here, I do the contact system, and one of the county hospitals where the fellows operate, they use non-contact systems. I'm very familiar with both Merlin and Resight, so that's what I would do. The advantage, as I said before, was if you're a very experienced surgeon, the contact system you can hold and do yourself, even if you don't have an assistant. But if you're an early learning person, that can be somewhat challenging to keep it perpendicular. So SSV is basically what we use. They certainly help you. But you can also train anybody, the nurse or whoever is helping you, for short periods of time to easily hold the lens. And that would be my recommendation.
Yes, I think what you've said is quite clear. For when you say what system you recommend for a new VR surgeon, the answer is wide angle system. Now, contact and non-contact, there are pros and cons that you've seen, and there are a lot of factors, and maybe the school of training that you've been brought up with, it's easier for a person. If suppose you're used to a non-contact based system, you've trained with that, then of course you would be much more comfortable with that. While if you train with contact, then you would be. So a lot of it also is based on that, apart from the other pros and cons. Also, as Dr. Chalam said, there is a bit of a simplicity in terms of economics also, where contact systems are, plus they are portable, you can take them, it's just the lenses that is you need once you have inverters on the microscope. So there is a bit of, apart from the crispness of viewing and some other factors which are there. But I think most important is having access to wide angle viewing systems, indirect viewing systems, without which, once you shift from saline to air to, if you use irrigating lenses, if you use the, it used to be a nightmare to operate with those lenses in the past, because once you shift to air and you could hardly see anything, and one had to keep on shifting various prism lenses. So today, I think the wide field lenses have changed everything. They go through smaller pupils, they go through multifocal IOLs, they go through, it may be great viewing with a well-dilated, clear pupil, but they allow you to do surgery through almost everything that is coming in your way. So wide field is what you should use. I think the second question is between self-retaining contact versus non-contact, which is better. I think Dr. Chalam did mention the self-retaining flanges is very useful. Even I use those because they help the stability. Even when you put the viscoelastic, the flanges, when they sit on them, they tend to hold it longer. Also, you could have an assistant keep an handle along with the flange-based lens, which may be more stable for the assistant to keep it on. So that is something that one has to look at, in your personal theater practice, what works best for you. What are the recommendations to reduce fogging of the lens when using non-contact systems? Yeah, so I've not used a lot of non-contact systems, and I think whenever some of the people who, the Biome and these, they have come to me to give me demos, and I do get this fogging at times, and fortunately I prefer the contact and I shift back to it. Many times I see them that the nose, the area from where the patient is breathing, they have to tape it specially or something. So there are different ways to do that. Even the temperature of the OR is sometimes, I think, changed to suit the less fogging or more fogging. And I think at the ASRS, somebody even talked about a device which was reducing the fogging by keeping it like a small fan nearby. I can't remember now, but there are some sort of things like that. Dr. Chalam, you want to comment on that?
Yeah, I mean, you already alluded to the important point I was about to mention, which is make sure the tape is really adherent all around. Especially in high-nosed people, this can be a problem if you're not paying attention. And often, sometimes the anesthesiologist also increase the oxygenation for other reasons, the blowing air into the area. It is also for other reasons to make sure you don't get any infections. You need to keep the area extremely close. That's usually most of the reasons you get fogging is because the nasal air is much warmer than what the atmospheric air is. And so that's why you get the fogging on it. That said, let us say you did all this and you're still getting it. Then at least with ReSight system, they have a solution that is sold. And our fellows basically rub it, and then it's a defogger solution. And depends on where you're in the world. I think that's one other way to take advantage of it. So I had the fortune of using, all cases that I do, primarily I use contact system. But when I assist my fellows and also when I train them, they use ReSight. And then ReSight is somewhat like what Manish mentioned as the mid system. It's like a 68, 70 diopter lens kind of a system. So for diabetic dissections, I try to, that's also very helpful if you don't have the 70 lens. And then we have some homemade thing because I have a Vogue lens that was made that fits into the green ring of the non-contact system. So I disinsert the lens and I put this lens. So the fellows get the idea, even if somebody is not there, to use the wide angle system, contact system. Wide angle contact 150 diopter lens is much more easier because it is shorter in height and it stays there without much difficulty. The 70-degree lens, on the other hand, is a little bit more difficult because it is taller and then tend to sway one or the other. For that lens, I use the green lens of the ReSight to hang on if I don't have an assistant. And that helps. I mean, unfortunately, the manufacturers don't make or suggest it, but it's just common sense idea, just to disinsert one lens and put the other one in, and that helps.
Great. Dr. Saurav Mahajan has two questions on any tips on using finesse loop for raising ILM flap and not pinching deep while using ILM forceps. Well, so both are based on good visibility, I think, more than the forceps. I mean, of course, you use the right forceps, which is there, which is the ILM forceps, which has a very fine platform to hold only the ILM. Or now they have the shark fin forceps, which also allows you, or a finesse loop, which has these small gradations which are there, which allow you to judge that it doesn't go deeper than that to pinch. But for all this, these are adjuncts. As I said, the technology is there, the instruments are there, but unless you have a crisp view, which to my mind, the best view is with the contact flat lens to do that. And if you are using it, I don't think you will pinch deeper because you'll keep the view in mind and you'll know exactly how that transparent sheath of the ILM moves, and you know that this is the right plane, and if it's not that, then it's not right. So I think it's the view which is very important. Vivek from LBPI, he has a question about usage of contact lenses over eyes with microcornea. Are they stable, or any other technique is to be used? Great question, Vivek. The only time I find problems with contact-based systems is in eyes with coloboma, small eyes, microcorneas, and I believe Vogue has this DynaView lens, which they have, which fits into smaller pupils. Only thing is that it doesn't come with flanges, which is something I have been telling Vogue to make something on that line. I prefer the one with the flanges, but they do have a smaller sized lens. I think Dr. Chalam may be able to talk about it. Yeah.
Well, this was designed by me in 2004, and it's called DynaView. And the reason we didn't put flanges was because, as it is, the eyes are so small, and putting them reduces the diameter of the cornea. So we made a 9 millimeter instead of the 11 millimeter at base on that one. So one disadvantage, of course, is somebody has to hold it, because that's very easy to lose the view if there is no flanges. But that is true. But we also made one other thing in that area. The concave contact that is on the, normally we use just to put on the cornea itself. But in this case, we made it a little bit steeper so that it can hold more viscoelastic DynaView lens. So that gives you a little bit advantage, but nevertheless, that's what we do. As far as the ILM peeling is concerned, we usually use BBG often. So, I mean, the staining makes your life very, very easy to, because I did some electron microscopy studies. This was long before the BBG was into the view. It's in 2006-07 time. And no matter what you do with the ILM pinching, we found Mueller cell put plates when you do the EM. So we can get away and say, well, look, we don't have anything. But if you do microperimetry on those eyes, you'll have scotomas. And I either with a small tano is commonly that what I use to raise a flap away from the fovea, so that is not affected. And once we have, then use any instrument literally to peel it off. But if you're pinching, then you're pinching something that you're not really sure what you're pinching. And from a biological point of view, I have some concerns about it. You see, I mean, as a physician, you need to do whatever you do with 100 or 100 times reliably and accurately, like an industrial engineering kind of thing. So if you have a thin retinas or a compliance of the retina is different, the same, you can't reproduce your pinching power at the same time. So to me, that's a concern. But that said, can you get away with it? Yeah, 9 out of 10 times you can. But when you don't, then you have, say, why I'm doing that way? So that's my answer to that. Yeah.
But I would still like you to tell Vogue to get the flanges on the Dyna. I would love it for these pediatric patients and for microcorneas and colobomas, where it's a great asset, because that's the only time I sometimes struggle with contact systems where because the regular lenses are a little big for those eyes. And
so their problem is basically number of sales. They don't sell that lens.
I understand. Yeah, that's what they told me, that the use is so limited for that particular requirement.
And I hope they have the ability to do custom make and charge more for people that has large volumes to do. It's not really hard to do it. It's just the same manufacturing process. It's paying attention.
Great. So how do you tackle the change air bubble entry under contact lens to change in corneal shape while tilting? Well, so that's something about stability. And if you put in a good amount of visco and put it perpendicular, or have an assistant hold it, usually it's not a problem. But once in a while, you may get an odd air bubble. All you have to do is go and put in some more viscoelastic, which is free from air bubbles, and that usually takes care of the situation. How do you prevent?
I have one small solution on that one. Basically, what you do is you lift the lens and then clean the undersurface of the lens. Oftentimes, what happens is the bubble can be on both the cornea, or it can be also in the visco that you already have under the lens. So I do both: wash with BSS the cornea to get rid of any bubbles there, and then you clean the undersurface and then put the visco on both. And usually that takes care of it. And the other thing is also, it depends on if you're doing during air exchange, this tend to happen more because the resistance of the eye is much less. So the buckling up and down can easily suck the air into that. That is something. And also if you have an assistant or if you're pressing it too much, that's when the air gets in. There can also be another problem. The same thing can happen inside the eye too. If you press too hard, sometimes the air can migrate into the antechamber. That can be a big pain. So you have to be careful with that.
Yes, yeah, that does happen. In fact, I was thinking somebody will ask about how to overcome that. Air bubble coming into a phakic or a pseudophakic eye at times, and that becomes a problem. And we usually put a viscoelastic or something to overcome it, and then wash it off, of course. Yeah.
I basically take out the air line completely, make it hypotenuse, push anything that comes into the eye, into the antechamber with filling with Helan.
Yes.
And then, of course, that causes some problems. Sometimes it makes it so deep that you may lose some view, but you got to overcome that. There is no two ways around it, because once it makes the path through the zonules,
it will keep coming.
It will keep coming. So your air infusion should be usually no more than 35 in that situation.
Sure.
So
how do you prevent inadvertent microabrasions in non-contact lenses? Non-contact lenses.
Okay, good. Probably what they were referring to is the non-contact systems has acrylic, which is, I don't particularly like it, but they don't have glass. So glass, I need to comment on this important thing, because when you use glass for making the lens, the scratching is unlikely. Acrylic, on the other hand, when they go through the sterilization, tend to get scratched very, very easily. I think that's what they're actually referring to. Well, I don't want to suggest specifically, but probably Merlin lenses should be used because they're glass made of glass. The same thing in the flat lenses also. One point that I want to bring to the attention is Obviously, Vogue has these disposable lenses, but they also have the same lenses made with glass, which last much longer, and they're also sterilizable. So I usually prefer them, but the operating rooms tend to prefer disposable ones because they can throw away. But the quality is always better, especially if there is a lens they make with quads, which is not basically scratchable. So in other words, it won't get scratched when you go through the thing. And that is my preferred lens. But they only make select few. I think they're not for sale. So if you have a flat lens with flanges and that is made with quad, that would last forever.
Yes.
Just like the watch glass, quartz glass kind of thing. So.
For shifting from non-contact to contact lens, which is recommended, mini quad XL or HRX with? Interesting question. Well, I've kind of grown in the last 20 years. I mean, I started with these mini quad XLs, and for me, that is my absolute go-to lens. But I use the HRX also. I have both of them, a few of them. So sometimes for different surgeries, I just pick up interchangeably. I don't really try to distinguish. They have smaller pros and cons in each other's context, but for me, both mean the same in terms of surgery. Dr. Chalam, you want to comment on that?
Well, both are designed by me. I'm very happy to be in.
Yes.
So the mini quad XL is my go-to lens still. Fundamentally,
Absolutely,
the reason is the glass is the best quality because of your index of refraction is still 1.42. So the light transmission when you put the endo illumination towards you is much more crisper with the mini quad XL. The HRX VT gives you a wider view, but it also, because of the index refraction goes to 2.12, it cuts down the amount of light that comes to you. So that changes the color of the retina. So it's a usage issue. And the HRX VT, originally we decided to develop that to take advantage of the pars plana viewing for ECPs. Can you indirectly do endocyclophotocoagulation, which not retina guys do, but glaucoma guys do. And that was the reason we worked on it. And that was, around 5-6 years ago, more recent advance in manufacturing technology, not a rocket science concept. It is just index of refraction so that you can actually see. It's like a wide angle camera lens, the wider the better, that kind of thing. That's what we did it for. But that's an interesting and good question, very knowledgeable question, because as long as you have illumination that takes care of it, HRF gives you a wider view than mini quad. But if you want pure, one thing you have to understand is 1.4 also gives you a better stereopsis than a 2.12 index. The same as, for example, the 70-degree lens Manish was mentioning is much better for stereopsis. It increases the stereopsis so well when you're doing thin membranes or multi-membranes in a diabetic, they're extremely useful. So the less dioptric power increases the stereopsis, and the wider one decreases the stereopsis. So that comes into play in judging which one to do that.
Thank you for clarifying it, because I always find myself go to the mini quad XL compared to the HRX, although I use both. But there is this, a benefit that mini quad XL still has, and I love that lens. Yeah.
And the other advantage you also have is the diameter of the lens is the other one where we can increase the view. So the mini quad XL diameter is larger. So the stereo in the periphery is much better because of that.
Sure. So Vivek is asking, do you see any deal breaker disadvantage in contact systems for someone using non-contact systems only? Is there a significant adjusting curve? Well, there would be a small edge. If you're already used to a wide angle system, be it non-contact, you just have to do maybe 10, 15, 20 cases in a row, forcing yourself to do it with contact. And I don't see why it would be difficult. You just need a good assistant at the beginning, because you may not be totally independent with the flanges to begin with. You could try that out and then shift. But as far as the flat lens is concerned, I don't see there's any problem for that purpose. It's only for the wide field lenses that there may be a small learning curve that I foresee, which can be overcome in most situations by a well-versed surgeon like you.
Yeah, flat lenses is straightforward. I don't think you need to worry about flat lenses. Is basically the easiest of the lenses to use. As far as the wide lens,
for wide field, yeah.
For the wide field, you won't have any difficulty. Just that somebody has to hold it. That's the difficulty.
Yeah.
In terms of your view, you're actually much more happy because your microscope is a lot more user friendly with the contact system than with the non-contact system. Because you're going up and down with a non-contact system, changing. Sometimes you need to exactly adjust the zooming with the widening the angle properly set up in a non-contact system. Whereas the contact system, nothing there. All one switch, inverting and averting is the only switch you use. The rest of it is like you're doing a conjunctival suturing kind of thing. So to me, contact systems are a lot more user-friendly. The only downside, of course, is, especially when you're starting, you need an assistant until you get used to them.
Sure. There's a question to you, sir. Which vitrectomy ring were you suggesting for self-retaining contact lenses?
Probably Reside guys may not like when I answer this question, but I am doing it in the green lens that has actually 13 millimeter diameter, and the HRX lens is usually 13 millimeters in diameter. They fit in. That's what I was using. My assistant, my fellows came up with this idea, not me, and they said we can do it. But of course, you have to be careful not to scratch your cornea because you're doing contact there.
Yeah.
So it requires
maybe you could share a photo or a small clip of what you do. Maybe we could have Lawrence send it as an email.
And I requested the Vogue optical guys to come up with this, and they're working on it. Yeah, whether you can disinsert the green and then put this one in the reside kind of thing.
Right.
Or Merlin, for example.
Yeah. And the next question is, what sterilization technique do you recommend for contact and non-contact systems? I think these days they're all autoclavable, as well as we do ETO sterilization for our lenses. In the past, we used to also put in formalin chambers some of these lenses. I don't think it's a problem to sterilize them.
Well, it depends on which country you're in. Unfortunately, in the United States, the rules have changed. For the first 15 years, we just used to put them in Sidex for 10 minutes and then just wash it. And
yes,
that's all.
Sidex was also,
because they're not going inside the eye. All you're doing is on the top of the eye. But then the FDA or the rule manufacturers, they had to get permission. So now they make it, then it became gas sterilization. Now, in states in the last 5-6 years, even that went out of way. They can't do that anymore. So it came to, we use Sterrod here, which is basically, I don't know how familiar you are all with it. It's a hydrogen peroxide based system, and it doesn't damage the lenses, and that's what we've been doing. But that's a good question.
And of course, the disposable ones now, US.
That is right. So the Vogue is trying to come with a disposable wide-angle XL system soon. So that may be great because that takes all these problems away. I mean, we do also have one other lens from Katina. That's the 68 diopter lens that Manish was basically talking about. So I actually use that lens for diabetic dissections because it's disposable. You don't use it that often, but when we do, so I am a big fan of the delamination technique. I normally use bimanual and try to cut the tissue, then cut the membranes. And I dry it with Avastin as much as I possibly can and get it plain so that way minimum bleeding and that kind of thing. But for the dissection part, I love the 70-degree lens.
Yes,
and
same here.
Yeah, and so the Katina also makes it those that are the 70 diopter lens the Vogue makes is not disposable. It is a costly lens, whereas Katina lens, on the other hand, they come in a pack of 12, and it will last forever. And they also come with a plastic holder, so somebody can actually hold it, and it works very well.
Okay, the last question that we missed one was asked. Dr. Fard is asking for, do you recommend office system by Topcon? Now, I personally have had no experience with it. Dr. Chalam, have you had an experience?
Me neither. I have seen in the trade shows, but I haven't used it. And the concept was use a Topcon light, at least at some version, which illuminates. And I don't have experience. I don't want to say something I don't know.
Same here. So I think that brings us to the end. Thank you everyone for joining and also asking all these questions. It helps us understand things better and also interact. And I've learned a lot from Dr. Chalam's talk and all the principles behind these lenses. And it's a great insight into how we view the eye and do our surgeries by using all these lenses. And if there are any more questions, you could still send it across to CyberSight, and I'm sure they can forward it to us. And Dr. Chalam, maybe you could share that photo with Lawrence, and
I will. And
it may be something that all of us may benefit with.
Sure, absolutely.
At some point,
We're in the process of with looking at any copyright, that kind of thing, but
Sure.
it's a very useful thing that came in the last 1 year time, and to circumvent basically exactly what the challenge was. So how do you do a perfect job without an assistant? And one thing is, well, why can't we use it on a non-contact and just put it in there? Well, thank you, Manish. It's a great great experience for, I hope, all the attendees and Ireland as well. And we'll stay in touch.
Thank you so much. Yeah. Bye-bye.